Hi, let's start with the pectoral region chapter. In this chapter, we'll be covering the four important muscles: pectoralis major muscle, pectoralis minor, subclavius, and serratus anterior. One important fascia, clavipectoral fascia, and mammary glands. So let's begin with the pectoralis major muscle. Before that, just put a simple diagram. Draw sternum, clavicle, first 1 to 10 ribs, scapula, humerus with the intertubercular sulcus. Red labeling shows the origin and blue one shows the insertion of the muscle. Pectoralis major has been divided into two parts. One is the small clavicular head and large sternocostal head. Origin of the muscle. Pectoralis major, as I said, divided into two parts. So clavicular head arises from the anterior surface of medial half of the clavicle, whereas sternocostal head arises from lateral half of anterior surface of sternum, medial parts of second to sixth costal cartilages, and aponeurosis of external oblique muscle. So just remember that clavicular head arises from medial half of clavicle, whereas sternocostal head arises from anterior surface of sternum, second to sixth costal cartilages, and aponeurosis of external oblique muscles. Insertion. The pectoralis major will be inserted into the intertubercular sulcus of the humerus, and it forms a U-shaped tendon. The anterior lamina of the U-shaped tendon formed by the clavicular head, whereas the posterior lamina is formed by the sternocostal head. Now supply of the muscle. It is supplied by two important nerves. One is the lateral pectoral nerve. Its root value is C5, C6 and C7. One medial pectoral nerve. Its root value is C8 and T1. Actions of the muscle. The clavicular head, it assists in the flexion of the arm, whereas sternocostal head, it assists in adduction of the arm and medial rotation of the arm. Remember that flexion, adduction and medial rotation of arm, it takes place at the shoulder joint. Clinical aspects of the muscle. There is one important clinical aspect, that is congenital anomaly. In this, as I said, there are two parts. Usually one part of the muscle will be absent, that usually the sternocostal part. Then clinical testing of the pectoralis major muscle. It is used to assess the tone and power of the muscle. Just ask the patient to lift the heavy rod. The clavicular head will be prominent. When depressing the rod, the sternocostal head will be prominent. Second muscle, pectoralis minor muscle. Put the same diagram, and origin of the muscle. It arises from third to fifth ribs near the costal cartilages. And insertion of the muscle, it is inserted into the medial border of the upper surface of coracoid process. So origin is from third to fifth rib and insertion is from medial border of upper surface of coracoid process. So nerve supply of the pectoralis minor muscle. It is same as that of the pectoralis major muscle, that is medial pectoral nerve and lateral pectoral nerve. Actions of the muscle. It assists in protraction of the scapula. Protraction means bringing the scapula lateral and closer to the chest wall. Depression of the point of shoulder while shoulder movement, and it is also accessory muscle of respiration. Mostly it helps in forced inspiration. So again, in actions, it helps in protraction of the scapula, depress the shoulder joint, and accessory muscle of respiration. So now let's talk about the clinical aspect. It is a key muscle of axillary region, because axillary artery just passes beneath this muscle and it is used to divide the axillary artery. Next muscle, subclavius. Just draw the head of the sternum, clavicle and first rib. It arises from the first rib near their costochondral junction. When it comes to insertion, it is inserted into the subclavian groove. Where to find the subclavian groove? It is just middle 1/3 of the inferior surface of clavicle. Nerve supply of the muscle. It is supplied by nerve to subclavius. It is branched from the upper trunk. Actions of the muscle. It assists in stabilization of the clavicle during shoulder movement by pulling it inferiorly and medially. Clinical aspect of the muscle. There are so many neurovascular structures passing behind this muscle, so it provide protection to those neurovascular structures. Those neurovascular structures are subclavian vessels, subclavian artery and vein, and trunks of the brachial plexus. Our next muscle is the serratus anterior. Just draw the sternum, first 1 to 10 ribs, and the scapula. So, origin of the muscle. The serratus anterior muscle, it arises by 8 digitations from upper 8 ribs from 1 to 8. Insertion of the muscle, as I said earlier, 8 digitations from upper 8 ribs. So, first 2 digitations from first 2 ribs will be inserting onto the superior angle of the scapula, as I showed in the diagram. Next 2 digitations will be inserting onto the medial border of the scapula, and last 4 digitations from the lower 4 ribs will be inserting into the inferior angle of the scapula. Nerve supply of the muscle is mainly supplied by the long thoracic nerve, or also called as nerve to serratus anterior. Its root value is C5, C6 and C7. And actions of the muscle. Its main action is a powerful protraction of the scapula. As I already said, protraction means bringing the scapula laterally and more closer to the chest wall. It will be helping in the boxing movement. So, and it also assists in overhead abduction of arm by rotating scapula laterally and upward. And it keeps the medial wall of the scapula in firm contact with the chest wall. Clinical aspect of the muscle. There is one important condition called winging of scapula. It is mainly due to the paralysis of serratus anterior muscle. So this condition is mainly due to the injury or any kind of compression of the long thoracic nerve in that region. Clinical features of this condition are there will be weakened protraction of the scapula, means their punch will lack the power. So while boxing they won't have the much power as normal person do. So when patient pushes the arm against the wall, medial border and inferior angle of the scapula become unduly prominent, and that condition is known as winging of scapula. As in picture you see that medial border and inferior angle. So let's start with the main important fascia, that is the clavipectoral fascia. Just put the simple diagram and start labeling it. Investing layer of deep cervical fascia. It is a fascia of the neck. It joins the clavicle, and below that there will be clavipectoral fascia, and inferiorly axillary fascia. So clavipectoral fascia, it starts from the clavicle and ends at the axillary fascia, and three muscles, pectoralis major, minor and subclavius muscle. Just put the another diagram. So this diagram will show the extent of the fascia very clearly. So let's discuss the extent of the clavipectoral fascia. The clavipectoral fascia extends vertically from clavicle above and axillary fascia below. When it comes to medially, it starts from first rib, costoclavicular ligament, and it blends with the upper two intercostal spaces. In laterally, the coracoid process, coracoclavicular ligament, and tendons of the biceps brachii and coracobrachialis. So just remember that. When it comes to extent, put three head subheadings: vertically, medially and laterally. Vertically, it extends from clavicle to axillary fascia. Medially, it starts from first rib, costoclavicular ligament, and blends with the upper two intercostal spaces. Laterally, it extends up to the coracoid process and coracoclavicular ligament, and tendons of biceps brachii and coracobrachialis. So there is another important structures which are will be piercing this fascia. So basically this clavipectoral fascia will be covering the pectoralis minor muscle, and it just lies beneath the pectoralis major muscle. So there are four important structures which are piercing it. There is one mnemonic called lat-lis. So lat means lateral pectoral nerve, thoracoacromial artery, lymphatics and cephalic vein.